Welcome to Breaking Point, a podcast from CAPC, the Center to Advance Palliative Care. In this limited series podcast, CAPC invites healthcare workers from across the country to share their eye-opening stories from the front lines of the pandemic. Listen as they give us an unfiltered look at their reactions to the demands they've encountered and the coping strategies they've employed as they reach their breaking point. Your host today is Dr. Diane Meier.
Hi, everybody. I'm Diane Meier. Thank you so much for joining us this week on Breaking Point. Today, we are joined by my longtime friend and colleague, Patrick Coyne. Patrick is the program director of the Palliative Care Service at Medical University of South Carolina, down in Charleston, South Carolina. And Patrick is in the field of palliative care an unusual leader because he's leading a palliative care team and he is a nurse, not a physician. And I think setting an exemplar for how leadership is not discipline specific. Leadership is kind of person specific. And Patrick has a number of years of demonstrating what a powerful leader he is. And I'm really grateful to you, Pat, for joining us today. And the purpose of this podcast is really to get some reports from the front lines about palliative care in the context of a 2-year pandemic. And would love to just hear from you about what it's been like.
Well, thanks, Diane, and I appreciate that really kind introduction. I think probably like everyone, palliative care has been hell. It just has changed everything from the way you function to the way you go home. And I remember in the very beginning, we were kind of all set up, ready to kind of do battle. And here in South Carolina for months, frankly, nothing came. And we're like, well, this is pretty good. We're missing everything. And then it came. And when it came, it was, I think it was overwhelming. We had changed a lot of things before it came, trying to be prepared. And, we went from a 5-day-a-week with an on-call situation to putting someone in-house every day or more than one people for a lot of reasons. One, I think there was great fear. We watched local communities close their palliative care programs because they got rid of, elective surgeries and not realizing the value of it. And for us, our census went down because elective surgeries went away. People were scared to come in the hospital, and we were waiting for this tidal wave, which seemed to take back then forever to get here. But once it hit, it did a lot. I think we felt better knowing we had good handoffs to people every day. But I think it also, why it gave better service to our residents and our patients and their families, I think it also stretched our team. And I think the hours became longer for everyone. And this is a great team. I'm really proud of them. But we see each other every morning when we round. We sit around the table every morning. We talk about every patient. We triage. We figure out where the chaplains need to be, where the social workers, where our volunteers need to be. And when we did that, we didn't get to see everybody's face every day. And that really, I think it took a lot out of us because this is our work family. And trying to keep up with each other was hard. And, I think everybody was scared. Not that we're not scared now, but we're not as scared.
Yeah.
And changing the way we did things. We're great at having family meetings, but nobody's coming into the hospital.
Right.
And so, we did a lot of workarounds, like we got iPhones for everybody. we got iPads on a lot of the units so that we could have these discussions and the family could actually see their loved one. And we were doing that early on, which I think helped a lot. And we were calling their chaplains or priests and really just trying to figure out who is it that needed to be there. I don't think I'm very tech savvy, but how do you have a conference call with 8 family members and trying to do all this? So there was a lot of things that we learned, and you're dealing with way too many deaths with families that can't be there. You're trying not to bring it home because every day would be a bad story. And I think we just basically circled the wagons as a team and tried to take care of each other. And we were trying to take care of the hospital. Right. Because the nurses, the residents, housekeeping, everybody was suffering.
Yeah.
And so, I've got a great chaplain and a great NP who started doing some basically debriefings. And I think that was really helpful to the other services. I think it added a little more weight for them, but I think it helped. And we do telehealth for probably 11 hospitals in rural communities.
Wow.
And our team was trying to do that. One of the smaller community hospitals had 11 deaths in one day. And, it's only an 8-bed ICU. I mean, how can we support them? So I think in a roundabout way, I think it helped us because I think we were helping.
Yeah.
But I think it also was another weight we were lifting.
Yeah.
And just an amazing group of people.
Sounds like it. I really like this conceptual framework you're naming, which is that your patients were the hospitals and the health system and colleagues working in every kind of role, because everyone is traumatized, not just the patients and the families. And so we take our ability to be present with unspeakable trauma and expand that, apply it much more broadly, unfortunately, with the same number of people we had before that was necessary. But I also hear you saying that it was helpful to your team to feel like you were helping, like you were doing something useful. That ability to be useful in a crisis is a luxury, is we were lucky to actually feel like we could make a difference. I think many of our colleagues didn't have that privilege.
I can't imagine doing this solo. And those who did, I can't give them more credit because it was exhausting with the team. And for those who are out practicing by themselves, it just had to be. I just don't even want to imagine.
Yeah. So tell me a little bit about your team and how the team itself has weathered these 2 years.
Well, I've got an amazing team. So we've got probably 10 people on our pediatric team, which were really during Delta pretty much untouched. Mm-hmm. I'm laughing now because I had them doing adult consults, which it wasn't a bunch, but it was enough because we had our adults in our children's hospital just because we were out of beds.
Yeah.
And so that was kind of fun. They kind of like patients who can't talk back, or, so we had a few laughs about that. And I think on the adult side, I've got a lot of nurse practitioners and physicians, but I also have a chaplain and 2 great social workers and a volunteer coordinator who did a lot of legacy work with families because our volunteers couldn't come in anymore, and really did a lot of work with the staff too. And I think the legacy work in its own way was helping with the distress, just a way to help support families and themselves, that a way of saying goodbye, and that I did my best. And that was important. I think more important than I think we knew, because a lot of the feedback from our residents has been they were happy to be part of that, where previously I don't think they thought much about it. And because usually there's a family to say goodbye to or a hug, and all of that was just not going to be there. And I think it was a break in the day that, as bad as it is, we still have each other.
So tell me about legacy work. What is that? What exactly do you do?
It's a little different around the hospital, and it's a little different based on the patient and the family, but it will be anything from doing fingerprints on a special stone. And we have a great volunteer coordinator, Jess, who can put anything on the stones. It could be the Boston Red Sox, the New York Yankees, a sailboat, an Air Force emblem. And she'll make up to 30 to 50 of these so that families have something. They'll do some heart sounds towards the end, especially in peds. Sometimes it's a handprint. It can be a lot of different things. It may be a picture if patients' families want that. So it's really kind of something that they can't be there, but they have a piece of them. And we'll sometimes do that if we're worried they're going to make it, just because it's a way for them to say, Daddy wanted you to have this, and we're hoping he'll come home, but here's something to, keep with you in your pocket. And, so when someone would die, the nurses and the residents would kind of do that together.
So let me ask you about retention and resilience and the approaches that you and your team use to keep people as well as possible during this difficult time. Are there things you look back on that you wish you had done differently? Are there things you look back on that you think were essential to supporting people?
I think when we went to 7 days a week, that was important. It probably could have waited a month. I wish I brought people back earlier.
Back together?
Back together. I think we had, at one point we were having weekly meetings with everyone, and I think we just found there wasn't time, but we continued the rounds. Probably the thing that's served us the best is we have a great group with dark humor. And pre-COVID, this is a group that would all go bowling together or out for drinks, or, it just is a group that does those things. I think we just recently had a retreat that was canceled 8 times. And I think that was helpful.
The retreat itself.
The retreat itself, because everyone had a chance to kind of debrief how they're doing, how their family's holding up. I think the other thing is, at least I've tried to be as transparent as possible. So when I'm meeting with the epidemiologists, I'm telling them everything I'm hearing, that it looks like we're going to get hit in 2 weeks. And, let's think about things we want to accomplish before it gets here and how we can do better, or what we can do better. I probably could do better at that.
But trying to tell people everything you know so they're
Yeah.
prepared and not blindsided by.
Absolutely.
Yeah.
And the team's been great at brainstorming. The iPhones was a quick thing. Administration listened.
Yeah.
Seeing patients in the ER was good to get there. We'd been doing that all along, but with COVID, we really worked hard to see them earlier rather than later. I think those things were really helpful. We worked a lot with our ethics committee, just talking about our issues, and they've been really good at a sounding board for us. And that was pretty helpful as well. So I think we looked for resources that we could find and how do we take care of each other. If someone had a bad day, I think everyone was going out of their way to make sure the next day was better. So I can take the extra patients, or why don't you get out of here early today? Or, I know your birthday's coming up, just go. So we can only do so much. And I think that was the other part. There came a point where historically, this is a group that would be here doing consults at 6:30 or 7. And you just kind of said, go home because I need you to come back tomorrow.
Yeah. Yeah.
And I think that was hard. For one day you can do it. And it was hard to go from a sprint to a marathon.
Right.
And that's something that really, I think early on as a team, we kind of talked it out, and I needed everyone to say it's okay to go.
Yeah. So that's fascinating to me because, there are some themes from this brief conversation we've had. And one of them is giving people a chance to say out loud what they're feeling and what they're experiencing with trusted peers, really. And that sounded like it was an essential ingredient. And then, of course, the other thing is the strong relationships that characterized your team before this hit, which is essential to be.
Yeah, I think everyone knew we had each other's backs.
Yeah. Yeah.
And that was helpful. I mean, that was survival.
Yeah. Patrick, I was intrigued by your comment about one of the ways that your team tried to care for and support our colleagues beyond the palliative care team. And you mentioned the word debriefing. And I wonder if you could tell us what that is and how you got people to be willing to engage in it, and how you trained your staff to be able to provide that.
Well, first of all, I didn't train my staff to do it. These guys they're good. So our chaplain, Hannah Coyne, no relationship. And one of our nurse practitioners, Katie, and down the road, others on our team who are social workers and all, basically they did a few things. They did what we called was a code lavender, and we did not think this up, but it was just bringing things to the units. It could be candy bars, it could be pretzels, it could be socks. I mean, it was a unit that was having a rough time and just saying, we appreciate what you're doing. But the other part was really, when we knew a unit was having a rough time, they would go to usually the unit's nurse manager or the chief resident, depending where it was, and just kind of say, do you guys need 15 or 20 minutes just to talk through the last 24 hours? And I know in one of them that I did not lead these. I was basically a fly on the wall, just trying to understand and gain from it. But in one of them, there were 35 people there.
Wow.
And people were calling in on their off time, just kind of, I think, checking in on their teammates, but also making sure that they did okay. And I think everybody was trying to circle back and figure out, could they have done anything better? And I think it was mostly checking in on each other and also, I think it was harder for everyone to take this home. And so to go home and think, this was, I think, an outlet to talk to your peers, where at work you never had time to do it. So if we could give them 15 to 30 minutes to just do that, it seemed like it offered some support. And we were able to bring in others that were helping too, the chaplain service here. There were some counselors at MUSC that also have started doing this as well. So I think it's evolved. I think there's so much more with the stress, and just not, I think everyone knows there's just not enough staff. And so how do we do this? And the resources at times were really hard to get. So these, I think, were opportunity just to say out loud, things have to be better, or how do we make them better, or are we doing okay?
Yeah. What feedback did you get from the staff that participated in these? Not your, well,
Yeah.
your team as well, but those who were participating in the debriefs.
I think they felt that it was safe to talk. I think it was a definitely a non-judgmental group. Nothing left that room.
Yeah.
And I think that was important. And it was also checking in that everyone was okay, and they were allowed to talk about this. And so I think those were important things. And how will they do better in the future? I think without any one being hard, it was just like, maybe next time we should do this or that, or maybe this hasn't been a good idea.
And your sense was that those who participated in it found it useful.
Yeah, because I know when others were held, a lot would come back. And so we're clearly not psychologists, and we're not trying to do therapy. I think we're just giving people an opportunity to safely talk about, frankly, what keeps them awake at night.
Yeah.
And that they're important.
I think that is a key role for palliative care teams. And in terms of what we were talking about earlier, the care of each other, of our colleagues, not only the care of our patients and their families. And you've made it explicit. And I think that's a very interesting direction for palliative care writ large.
It's something that you can't put on your mission statement because you're hoping you'll never do it. And if you're trying to survive, it's not a billable option. It's the right thing to do. And I think long as we, as palliative care, keep doing the right thing to do, you become an entity that everyone needs and knows the value. I know during the pandemic.
Go ahead, sorry.
I'm sorry. I know during the pandemic, I think the health system has a better impression of palliative care, or a better, but also greater understanding of palliative care than they've ever had.
That's been my impression as well. I want to say thank you again for your kindness and generosity and revisiting the trauma of the last 2 years and sharing with us the many things you did that took the edges off it and made it possible for your team to keep serving our colleagues and our patients and our families who need us. Thank you for that.
Thank you for listening today. For debriefings, the Emotional PPE Toolkit, and more, visit capc.org/COVID-19.